Well, first of all, benvenuti in Italy. Unfortunately, the weather is not nice today, but I hope that you have enjoyed at least yesterday or the day before. And I hope that also today will be a very important session. All the session will be very interactive, because for us it's very important this moment of meeting between doctor and patient in a different scenario that are not the normal clinic. So I hope that there will be a lot of questions that came for the floor, and we are at your disposal to try to answer, but more my guest than I, to be honest. Okay, first of all, before to start this round table, that the topic is basic and clinical research in amyloidosis diseases. Where are we going? I would like to introduce you Professor Julian Gillmore from the NAC in London, the NAC in London, that is more for clinical, and Professor Vittorio Bellotti from Pavia, Italy, that instead is more from the research point of view. So if we want to, we may start. I have some questions. We may start with the first question. What do you think?
Actually, we have a few slides that can help in making questions between us and the audience. And if we can start with the first slide, maybe.
I follow you without any problem. Tell me
images can help in generating questions. And from my part, I will start with the picture. Can you show the first slide? Not the one we decided together 5 minutes ago between me and Julian, but the one we prepared 1 week ago. Actually, the discussion in the previous section was very, very helpful and very interesting, and maybe we will take again the issue later on. But if you can have the first slide. Actually, the first slide is the journey of protein. Actually, I'm a biochemist. I'm an MD, but most of my time on biochemistry. I work many years with Julian and it was a wonderful time for me. Actually, yesterday, someone discussed about the dynamic of the clinical story, of the natural history of the disease. But there is a dynamic in the protein from when it's synthesized in the tissue and when it's deposited as fibrils in the target organ. And many of these proteins, including TTR, are beautiful proteins that do a nice, very nice job all along their life in the native conformation or in the natural conformation, but they become pathogenic for mutation or other reason that we still do not know. And yesterday night, I'm looking at the slide. No, this is the great one, but we decided together 5 minutes ago, but next one. This is the journey of the protein. You see what I was saying about the beauty of the protein. We have transthyretin here. I'm particularly fond of lysozyme because we started working on the amyloidogenesis of protein just on lysozyme in 1995, just in London at the NAC. But I was telling that I was thinking yesterday night about the presentation. I realized I'm not particularly proud of this, but I spent almost 15 years of my recent life in trying to understand why different proteins can, in some circumstances, can lose their structure, acquire a partially folded conformation, so they lose part of their beautiful structure. They maintain some bone, some minimal structure like this, and then become suitable for aggregation. And the reason why this occurs in vivo is still a mystery. Actually, we have many hypotheses. We work a lot with models, but for certain, we don't know exactly what happened in vivo in order to have this transformation. But this is key, and this is now well recognized that we need this step in order to make amyloid. In order to transform this protein into this species, you need energy, and the energy are probably mentioned yesterday, shear forces, mechanical forces, pH, but these are energy, and we now are in the condition, because we know something now, we are in the condition to say that in order to transform this protein into this species, this dangerous species, we need a certain amount of forces, and this can be quantified. You need from 5 to 100 piconewton of forces in order to have in vivo this transformation. Actually, 1 piconewton is 10 to minus 12 newton, so it's a precise energy you need to include in the system. And you can reach probably many districts of the body, probably the heart. Yesterday was mentioned the carpal tunnel, the spine, or other origin where you should generate these forces. Actually, if you have more forces, you destroy the protein and you don't have amyloid. If you have less forces, probably you are not able to transform. But this is something interesting that the biophysics and the biochemistry have discovered and very important. When you have this species, then the journey of the protein starts, and at least you can go into small aggregate, real fibers, and deposit it in the heart. But what happened here is not just a transformation completely of all the protein into this journey, because in the environment, in the biological environment, you have other pathways of degradation. And if you can give me the next slide. I have just 2 slides, not too much. We can move. Actually, this is a model of what can happen. You need energy. We have several hypotheses of the energy that you need to start a kind of dissociation of the tetramer. You have seen many cartoons all over the presentation yesterday about the mechanism of disease. Actually, we go more into the details. So we have to act with this arrow on the protein in order to change its conformation, to go into this intermediate state, in this particular species we have seen. But when you have this effect of dissociation, the protein loses its natural protection against degradation. So when you remove the structure of a protein in a biological milieu in the body, it's become very susceptible to further degradation. So we have a disease here that takes 30 in the worst scenario, but 60 or 80 years to become pathogenic. But what happened all along this time? Because every time the protein go into the condition of the 50 piconewton or so, we can lose the structure. But what happened on this long, what we consider the long lag phase before having the disease? And we hypothesize that along this time, next, the protein is degraded, because actually when you lose the structure, it becomes susceptible, and probably in a milieu where you have proteases and many mechanisms of protection, the protein is degraded. But the continued formation of this partially folded state at a certain point in the life of a person, and here the individual environment is very important. You can have the start the aggregation. And if you start the aggregation and make fibrils, then the kinetics change completely in TTR amyloidosis. And this arrow that you see here are the arrow that try to recapitulate the rate, the kinetics, the speed of transformation. At the beginning, you have big arrow, protection, you go to degradation, and you have this transformation with a small rate. Then when you have the fibrils, the rate changes completely, and you have acceleration in transformation into something different. So I'm a biochemist, so in enzyme, you can imagine that 90% go into degradation at the beginning, but when you have fibrils that is has a catalytic effect, 90% of the material go in the other direction. So this is a step that changes the story of the in vitro, the formation of fibrils, but can have a remarkable effect also in the clinical. And so you have probably in the biology of the disease, two patterns. One is degradation and mean protection. Degradation means that every protein has a degradation, and we generally take a protein when it's mature, it's older, we cleave in small pieces, and all the residue, all the amino acids are recovered and used for another synthesis. So this is natural physiological process. But also we have fibrillogenesis, and you see here is thermodynamic. This is a concept that you can make easy. So the fibrils per se are the most stable structured protein in the planet. Actually, are the structure of protein with the highest stability. And you have, for numbers, you have minus 12 kilocal per mole in the fibrils and 2.5 kilocal per mole in the native protein. So it's a hole, it's a funnel. When you have the fibrils, everything starts to go there because actually the stability dictate the transformation. This is something that we, in any case, with the therapy, we should try to avoid. So the issue is to understand better this, and of course to try to modify what happened in this pathway. Next slide is on the activity that we have now on the clinic in order to change the pathway of I described. Julian.
Yeah, so just to follow on from what Vittorio was saying and translating that perhaps into the clinical situation, I think, you know, the way that certainly we have thought about amyloid accumulation, if you like, is that it's an equilibrium, isn't it, between the rate of amyloid formation and the natural rate of amyloid clearance. We do know that, as you said, amyloid is incredibly stable, and you know, in order for the body to clear it, the body does not clear it terribly efficiently. The other thing that's striking about amyloid when you look at it under the microscope is really the absence of an inflammatory reaction. You know, when we look at tissues full of amyloid, there's very little inflammatory reaction. It's amorphous, eosinophilic material with very few cells around it. So the immune system in general is not terribly interested in amyloid and therefore perhaps doesn't clear it very efficiently. And if you have uncontrolled amyloid formation, particularly, as you were saying, if you have a seed of amyloid, then it will accumulate relatively quickly. And invariably, the rate of accumulation will exceed the rate of removal. And in that situation, amyloid accumulates. And what we're trying to do with our treatments is to slow that rate of accumulation, either by reducing the precursor protein concentration in the bloodstream, or in the case of TTR, by stabilizing the TTR protein. Of course, there are some unproven treatments at the moment, but there's some exciting research in terms of removing existing amyloid deposits. And it's obviously pretty attractive, isn't it, to potentially be able to accelerate that rate of natural amyloid clearance, and whilst at the same time having drugs to slow ongoing formation. And I suppose if we're thinking about the future, that combination is certainly a pretty attractive combination. I don't need to go through all of these. Over to you, Vittorio.
Actually, this slide was first presented at the retreat of the Department of Internal Medicine at UCL when we were both on that place. Actually, it's a scheme of, actually in general, how we think modern medicine is moving from observation in the patients to generation of new drugs or new device for a better treatment. And I will leave this epistemological framework to the audience eventually to see where every one of us is located in this ring of activity from patients to patient, because this is our main mission and issue and goal. But now probably Giovanni has some specific question, and we hope we have question also from the audience, starting from what we have presented.
Okay, thank you very much to both of you for your presentation. Probably for us, no really immediate, but each time, as I mentioned, each conference or meeting, you add a little brick of knowledge, no, from our patient point of view, so we appreciate. Now I start with some question, and as you mentioned, we wait also for the audience. The first question that I would like to address to you, taking in consideration the necessity to detect the earliest possible the disease, I am aware that there are some studies focused to understand when start treating asymptomatic patient. Could you provide us more detail, please?
This is a question for a clinician, please.
Thank you very much, Vittorio. It's a very difficult question, isn't it? Because I think from the perspective of ATTR amyloidosis, knowing what you've just told us about the fact that once you have a seed and once you have some amyloid, it acts as a template and accelerates. And the fact that we have drugs at the moment that are very good at slowing progression, potentially stopping progression, maybe allowing a little bit of regression, but we don't have drugs at the moment that reverse the disease. So the temptation, obviously, is, as a clinician, I think, is to treat as early as possible. And you said pre-symptomatic. And I think, we have a trial at the moment, don't we, called ACT Early, in which we are treating asymptomatic carriers with a drug to try and prevent onset of the disease. And that's the first prevention, the first prevention trial in ATTR amyloidosis. In fact, I think it's probably the first prevention trial in any form of amyloidosis. So that's pretty exciting. But I think what we need to appreciate as well is that we don't really understand the early natural history of this disease. And we know that there is variable penetrance. One can carry a mutation that is pathogenic in one individual in the family and not in another individual in the family. And so there is a lot to learn about that early natural history of disease. So whilst on the one hand, all logic tells me, and on the basis of what Vittorio's told us, that we should be treating as soon as a patient's at risk, on the other hand, we don't have data at the moment, I think it's fair to say, to support that. So to answer your question, I would say as soon as there's evidence of disease, we should treat.
Can I add, but probably according to the scheme, probably we are here. From moving from basic procedure we have established in general to some specific diagnostic activity, molecular diagnostic, to genetic of the mutation in the protein, but also the environment, probably extending the genome analysis. We will come out with some crucial genes that are involved in making susceptible to the disease. So probably in the future we will have some information about the gene that in any case of protein that are involved somehow creating a risk, and we already know that we have some risk protein, some polymorphisms that make at risk the disease. Probably we are here in the molecular diagnostic. Yesterday we had a nice presentation about the progress in the contribution of AI in echocardiography or other system or simple diagnostic procedure that can provide important clues on the susceptibility of the risk. Actually, I think we'll move faster in the prediction, or hopefully associating prediction to therapy, because prediction without therapy open another big issue for all of us.
Vittorio, can I ask you a question about the susceptibility? Because, we were talking earlier about preventative treatment, and if you could identify which patient is, or which individual in a family, for example, definitely is going to get disease, then obviously you would treat as soon as you know that. Where do you think the research is going to take us in terms of identifying susceptibility factors? You mentioned genetic research. Are there any other aspects that you would be thinking about in terms of susceptibility?
Actually, we look at some epidemiology. For example, we noticed that wild-type TTR, amyloidosis, somehow seems to be related to super physical activity or some job, and particularly heavy job. You have a discrepancy between male and female. So we have, from the epidemiology to the molecular basis, actually we have to fill the gap. Probably the slide I presented before, in which we had this degradation process, how many proteins are involved and how many individual factors are involved in making more or less efficient the degradation. You can imagine that every one of us will have a specific capacity to degrade, to deal with the protein. And this is, according to some, all the study, we have some variability. Yesterday, the heterogeneity, variability was an issue in the clinical report. Probably this is related to something that we don't know. We start grasping. But I think if you just put your finger on the bottom, there is another sentence here. Can you just, the next slide. Andrea. Oh, actually, we make enormous effort as a biochemist that we are quite neglected now as a field. But I like this sentence of Richard Feynman: what I cannot create, I don't understand. I think all this part of the epistemology that should be considered, we are struggling in creating models from the test tube to animals, etc. Because I think the models are not only important for having something in which we can test device and drug, but is helping understanding the disease. So the effort is try to create model more and more closer to what happened in vivo. Is not easy at all.
Can I ask a related question again, Vittorio? We think of amyloid or ATTR amyloid, or in fact all forms of amyloid, we think of it as a misfolding disease, don't we? And we think all about fibril formation. The research is so focused on fibril formation. But what about, do we think it's a failure? Could we think of ATTR amyloidosis as a failure of clearance? When you get to 100, you've always got ATTR amyloid deposits. Maybe everyone is making ATTR amyloid fibrils, if you like, their whole life. And at some stage in life, you start failing to clear them. Could we be thinking about it like that? Do you think that's an avenue for research? Is it interesting? Am I talking complete rubbish?
No, you're always right, Julian. You always make very intelligent questions. Actually, yes, I think you're right. Actually, we see in the model that is an equilibrium. What I can add is probably we don't even know. Yesterday you presented the conclusion about, you made a mention. If you just reduce by 20%, you reduce the product by 50%. If you reduce by 90%, you reduce it by 100% probably. Actually, but we don't know how much of these 3 micromolar circulating TTR go every day into amyloid. Actually, we don't have this number. Actually, it could be 0.1%, 0.01%, and it can change along our life. And probably aging also change. We don't need probably the fibrils to change the rate. Probably it's enough to change the extracellular matrix composition to change the rate of transformation. I imagine the amyloidogenesis as something like in a lab or in a factory. You have something arrive and it's transformed, but the rate can change a lot, and not only caused by the presence of fibrils, but also some modification of the extracellular matrix. The beauty of the extracellular matrix can degrade or can be lost along aging, and aging as a factor in the tissue. So it's possible that I add another very technical issue. If you, we talk about forces, and someone yesterday talked about shear forces. You know which is the forces you have in the shear flow of a fluid normally? It's 10 to minus 16 piconewton. So shear forces per se are not enough to do anything to a protein. What is the forces? The forces are creating is when the flow of a solvent like blood or serum move over hydrophobic surfaces. Like collagen is on hydrophobic surfaces. The combination of shear flow and the exposure of hydrophobic forces make the difference. You can reach the right forces for unfold the protein only if you are in the condition to have shear forces and hydrophobic surfaces. So this is a combination. And you can imagine in aging you have a modification of the environment. And if you change the surface, you change the forces. So this is quite a difficult biophysical concept, difficult to calculate exactly, but I think everyone can understand that this is a possible mechanism. So the complexity is also based on changing the environment, and we change the environment day by day with our activity, with almost all the effect of the environment around us.
Yeah, and I suppose what you've highlighted is that from a clinical perspective, we don't have an assay which specifically looks at the rate of amyloid production and specifically looks at the rate of amyloid removal. So we've got overall, is a patient accumulating amyloid? Are they regressing amyloid? But we don't have a specific assay for the formation and the clearance. And so to some extent we're in the dark, and that's surely got to be an avenue for research in the future, hasn't it? Yeah. You've got some more questions.
Yes, if there are no questions for the floor, I may address to you another question. Or...
Question over there.
Yeah.
Gentlemen, can you hear me? Is it on? It is very interesting and fascinating. I'm Jamie from New Zealand. I've got another scenario to throw that to you because of late, as a patient association, there are 2 cases of women. They are in their 60s, and both of them have had cancer in the past, and it's during the diagnosis that they found that they have wild type. So I'm just wondering whether there's any research that has focused on women particularly that have come through a certain type of condition and only to find that they have wild type, because this is the new one that I've encountered. I know in men, they are oftentimes very active, and I agree that for some reason when they are farmers or they are sportsmen, they tend to have the wild type. But these 2 women are quite intriguing to me. Like, is it because of their condition before, or because they're not really old? Thank you.
I think you've highlighted a really important point, which is that if you look in biopsy series, the ratio of males to females with ATTR amyloid, if you look in cardiac biopsy series, it's more like 60-40. But in clinical practice at the moment, certainly in cardiomyopathy clinics, we see 90% men. So, and we have this, in clinical practice, we have this cutoff, which is a sort of slightly arbitrary cutoff of wall thickness where we say if the wall thickness is not more than 12, the heart isn't thickened. But it may well be that in females who are, slighter, if you like, the natural wall thickness is substantially less, and that we should be, to get to 12, their wall thickness may have doubled. They may start from 6. So I suspect that we're actually missing females. We're not diagnosing females with this disease, and I think probably that is what you're highlighting. Vittorio, from a basic science perspective, we do nonetheless always seem to have 60-40. It doesn't matter what type of amyloid, you at least have 60-40 males to females, it seems. Do you know why? Can you tell us why?
Unfortunately, I cannot have an answer for this. It's amazingly important to have this observation and to have the possibility to investigate deeply. I think the young people with wild-type TTR can provide us an enormous amount of information about all the system of TTR amyloidogenesis. Actually, it's very, very important. Many factors can play a role in this case, but I'm really concerned about the fact that you have this kind of early diagnosis for the wild-type amyloidosis.
Is there any evidence in terms of amyloid fibrillogenesis or anything in the lab that makes you think that sex hormones might contribute or play a role in amyloid formation?
Unfortunately, I don't have any clues, or the literature, to my knowledge, actually, is still something that we don't know. Actually, the microphone.
Wanted to ask Professor Bellotti if you would like to expand on the first step of the kinetic scheme that you was showing, because I might be wrong, but during these 2 days, when I saw a graph about TTR concentration, my understanding is that measures the tetramer and also the monomers. So I'm wondering if there is something to be learned by measuring the amount of monomers that are free, which is the critical concentration that then triggers the other process. And also, I assume that the dynamic of the dissociation will depend on the variant. So this might be informative also of a difference in affinity and therefore in clinical development. So if you could expand on that, thank you.
Actually, the idea to have a tool to detect the circulating misfolded form of TTR is a goal everyone is pursuing. Actually, will be extremely important. Professor Selicius yesterday presented this peptide. We know that it was tried by Jeff Kelly years ago. I think the first observation in Science Translational Medicine was, I think, 7 or 8 years ago, and we were always expecting something to use in the clinical practice. But so far, I think it's so elusive, the monomer, the fragmented. The other thing I can say, and this was in the first slide, and we have learned a lot from one protein to another. So I think what I learned, for example, in my experience on beta-2 microglobulin was extremely helpful in my experiment or my work on TTR. But the concept of circulating misfolded form is really tricky, because actually when you misfold, you are rapidly degraded. You go into a pathway, or you deposit or you are removed, or because the body does not tolerate too much the misfolded issue. So I think the difficulties is because these species are so elusive, and they can present themselves as a monomer, dimer, trimer. We have the experience of A-beta in Alzheimer. The oligomers can be multiple of species and so. circulation is not a good place for misfolded material, actually. I think it's difficult that you can imagine that you move in the extracellular space, you can have fluctuation day by day, can be modified according to the composition, and also in the day can be different. So I think it's still a very, very important but unsolved issue. Silicius is very optimistic about. I'm also, because actually it would be great to have it. So far, I think there is a lot of work to be done. The second question was, or the third or the fourth question was mutation. Yes, we have variant, but this is amazing. We have variants, like the Prolin 52. I spent a lot of time on this variant, Prolin 52. The Prolin 52 we analyzed in UK, in London, had cardiomyopathy around the 40s. The family had this disease in the... But we have the Mexican cohort in which we have the eye and minimal. So this is something amazing. So to have this, yesterday someone asked about geography or this is make the complexity of the disease. And so in general, we have a good correlation between amyloidogenesis and instability. But it's not strictly related to what happened in vivo. This is something that definitely the environment in which the proteins stay is extremely important. I think it's the third part of the, but it's the most difficult. This is why we tend to stay on protein, actually, because the complexity of the environment is very difficult to tackle.
There's one question here.
Professor.
The degradation hypothesis in sex. We know that the immune system, we have a sex dimorphism. So women and men have different ways of responding to immune, different response types in the immune system. So that may be one explanation that women actually less commonly have this severe infectious disease like men. So we know that it's known as sexual dimorphism, and with aging, you also have a decreasing immune system. So decreasing clearance mechanisms and differences in the immune system between men and women could well be a mechanism.
People don't see you if you stand up, actually.
Oh, sorry about that.
It's very good observation.
Yeah, and the second question I have, do you have any evidence of transcriptional errors?
You?
You know what I'm talking about? So
No.
transcription can have errors. So gene transcription can cause errors. So you may have protein species caused by transcription errors, which may be more amyloid prone.
Actually, the concentration will be quite low. Actually, in the transcription error, you should have a limited amount of protein. The chimerism could be another issue associated to have some clone producing some mutation and you don't detect, but only detect in the fibers at the end. There was some cases in which you can have chimerism more than just simple transcription error that will be self-limiting, I think, in terms of disease. Because actually, we never forget, and the master of concentration is Julian here, we should reach a certain level of concentration to have the disease. So I don't think, probably yes, but I don't have any evidence of the effect. But the chimerism is an issue. It can be misleading sometimes.
I think maybe Jean-Christophe would like to say something.
Yes, Professor Gillmore, you told us about treatment which may deplete amyloidosis. So there are some promising clinical trials for cardiomyopathy where amyloidosis is mostly focused in the heart. Do you really believe that for polyneuropathy, we can imagine to have such a treatment when amyloidosis is dispatched in most all the body without having very strong side effect and quite a toxic drug to do that?
So I think your question is a good one, in that there are a number of issues, I think. Firstly, in terms of amyloid or drugs to try and accelerate the natural rate of amyloid removal, we really don't know at the moment how those drugs work. We have evidence, and Vittorio will tell us from our basic science models of a drug that we tested in London some years ago, and we have evidence of how it's likely to work. These drugs are likely to clear amyloid. In terms of, to answer your question slightly more specifically, in terms of the toxicity, it's very possible, isn't it, that if we create too much of an inflammatory reaction, if we overdo it, if our drugs are too good and they rapidly clear amyloid, that actually that will be associated with some toxicity. And it may be that we need to find a balance where actually we clear amyloid, we accelerate the natural clearance, but not too much, so that we don't get toxicity. Again, this is all speculation, because at the moment we really don't know how these drugs work. But if they work how we think they work, by activating macrophages, we'll hear more from Vittorio in a moment, it may be that we can overdo it. And it may be that we have to find a balance where we can, if you like, silently, but nonetheless efficiently clear away amyloid. That's the aim, the target. Vittorio, can you tell us about the mechanism of amyloid removal that you helped discover, as it were?
Yes, actually, the idea to stimulate the reabsorption, because actually there is evidence that you can remove naturally. If you stop the production, the amyloid can be removed. Even if I think that amyloid is extremely heterogeneous in the body, yesterday we had a one-to-one discussion about the removal, and there is the experience, for example, of the ARA amyloidosis, the dialysis-related amyloidosis, in which you can shift from dialysis to transplantation. In this case, the amyloidogenic protein beta-2M go down, and in this case, you don't have any more symptoms. But there is the Japanese experience in which after 20 years after transplantation, in which you don't have any symptoms of amyloid disease, at the autopsy, you still find amyloid. So I think there is an heterogeneity in amyloid deposits. There is something that you can easily remove, probably, the most soft part of the protein. And there is something that is very difficult to remove, and we have the experience of amyloid extraction from tissue. In some cases, it's extremely difficult to remove, to remove from the matrix. This is my experience, and in the lab of Julian and Mark Pepys in London was the idea to have a target through SAP at the amyloid, and then to use an antibody that can target the SAP as immuno removal of the protein. And we had the good evidence of the activation of complement, macrophage. So the picture you have seen yesterday, I think, for the antibody was very nice. The movie we saw yesterday on the macrophage, giant cell occupying. And this is a very old idea. Now it's becoming real, because actually the antibodies, humanizing the antibody, modifying the antibody is becoming more and more effective, and so, and we know more. But the issue of the equilibrium between efficacy and side effects is still a problem actually, and will be very important in the next year. In this case, I think to have good models of the disease, mouse model, and Julian has a beautiful model in London, can be useful in order to see which is the effect of complete removal by immunological approach. And I think for safety reason and for efficacy reason, I think the mouse model will be still very important in this case.
So you told us that antibodies potentially, at least in a mouse, and we think in humans, work by activating complement, which brings in macrophages, giant cells, and they chew up amyloid. What about the heart versus other organs? We know there are lots of macrophages in the liver and the spleen, which are organs where we can perhaps see regression more easily. But in ATTR amyloidosis, we're talking about the nerves and the heart. Do you think those will be more difficult to access in terms of antibody therapies, or are you optimistic?
There is another completely different issue here. It is the stability of the antibody at the site of localization. We really don't know, because actually in order to have the activation of complement, and so we need to have the FC, intact FC. It is possible, and we have evidence that when the antibody reaches the extracellular matrix, this is confidential, Julian. The extracellular matrix is full of metalloproteases, and I have evidence that when the antibody go there in some tissue, they can be chopped. If you chop the FC of the antibody, no way to activate complement at all. So it's possible that we reach the target, but the efficacy is remodeled, like a resistance to the efficacy of the antibody. So I think there is still a lot to learn about the mediation from binding the target to activation of complement. Another issue is opsonization. I'm entering into some more technical detail, but opsonization is a part of complement that bound to the cell in general to activate complement. It's not known how the opsonization work on fibers. This is something to be clarified, because it's a piece of complement that should attach the target in order to activate all the cascade. So every time we touch something, we enter into a complex system. But it's promising. Actually, it's very promising, the therapy with the antibody. I trust this can be very useful there.
If there is no other question, I have one question for Julian, but also for Vittorio, if we wish. Julian, as you may recall, in the past meetings, Professor Adams, Conrad, Jean-Christophe, and I talk about the combined treatment. Are there any developments with this regard?
So it's very attractive, isn't it, to think about combination therapy. And I'm going to come back to this question in a moment, Vittorio, because you've just educated me about something that could be very, very important, which is relevant to what you're talking about. But I think when we're thinking about combination therapy, we either want, at the moment, we're thinking about the combination of a gene silencer to remove most of the TTR in the bloodstream, and then potentially a stabilizer, and adding in a stabilizer. And obviously that's very attractive, isn't it? You remove most of the TTR from the bloodstream, and then you add in a stabilizer to stabilize what's left. There is, and we'll come to this in a moment, Vittorio, because you can explain some of the science that you were telling me about in a moment. But what we have in terms of clinical data is really from the Helios B study, which was the study of vutrisiran in ATTR amyloid cardiomyopathy, And there was a suggestion of benefit of combination therapy over monotherapy. So in other words, the patients on combination therapy appeared potentially, and I'm being a bit cautious with my wording, to do better than the patients on vutrisiran alone. These were patients on vutrisiran plus tafamidis. The study was not powered to answer that question, and we have a bigger study that's due to report next year, CardioTransform, which really has the potential to answer that question. The other, before we go to the basic science, just very quickly, the other combination that is obviously very attractive in my eyes is the combination of accelerating removal of amyloid with an antibody and slowing production of amyloid with a drug, either a silencer, a combination of a silencer and a stabilizer, or a stabilizer alone. So that, there's we've got a lot to learn about how to use these drugs, what will we, logically one might think if you have a patient with advanced disease, you would hit them hard with an antibody treatment to try and remove existing amyloid early on. And then when you get them, hopefully you reverse the condition through the antibody therapy. At the same time you would start a stabilizer or a silencer or both, or an editing drug to stop ongoing production. So we've got a lot to learn. It's attractive, but in the meantime, Vittorio was explaining to me earlier something that is fantastically interesting and could be really important. Vittorio, do you want to take us through it?
Yeah, it's really a privilege to have the possibility to, it's really a privilege to discuss with clinicians like Julian or Laura or others. And I think it was the important part of the sense of my activity, my life. And today we had this presentation by Julian, and yesterday in the evening I looked at the New England Journal of Medicine. It's just released yesterday. And what I learned also in my experience is to be very, to look carefully to the details in research. And one thing I found was this low level of thyroxine, circulating thyroxine in 8 patients, in 1/3 of the patients with this new therapy that abrogate the TTR at the level of unprecedentedly obtained, because actually we have 90%, yes, 90% of reduction. And the question I made this morning, and at the beginning probably we didn't hear me so well, so we had some, we didn't understand each other, but again, it was thyroxine in blood in every one of us, circulating, not bound predominantly to TTR, but to another protein that is thyroxine binding globulin. And in the years in London, I was studying this aspect. And so very little amount is bound to TTR. So the question was, like all the inconsistencies are important in science, the question is, why you have low thyroxine circulating if you just touch a protein that has no role in thyroxine circulation? And we start thinking about. So it means that at 90% reduction of TTR, you touch the transport of thyroxine by TTR. So it means that you are at this threshold in which you are start touching the transport of thyroxine by TTR. It means that the thyroxine is all bound, the people has this reduction of 90% are in the condition in which all the thyroxine are bound to thyroxine binding globulin. So, because the affinity is 10 to minus 11. I like numbers, but very, very high affinity. So this is circulating. And a small amount is still bound to TTR. If you just put some thyroxine or make the thyroxine at the equilibrium, Actually, this is thyroxine. This is the thyroxine binding globulin because we like to have scheme. Probably this is TTR. You have thyroxine in the pocket. This is the same pocket occupied in therapy by acoramidis, tafamidis, on any ligands you can imagine. So probably when you reduce 90% the TTR and you have the homeostasis of thyroxine level, you already occupy the TTR with his natural hormone. So you already have reached both goals. You have reduced the circulating TTR, but the remaining TTR is already stabilized by his natural hormone. So it was an interesting discussion between us that we came with this scheme, and probably this could explain, or we start now discussing, why probably the combination you already have obtained the combination therapy by his natural hormone. This is an hypothesis. It came just at the discussion, and this is the value of meeting, of staying together, discussing, having free time for discussion, and so we will leave probably with this hypothesis that we enjoy discussing with the scheme that became a slide in 5 minutes.
In the meantime, you can appreciate from the slide that that's what I'm expected to understand when I speak to Vittorio, is a wiggly drawing like that, which is always challenging.
We need a mic here, please.
The mic? No, it has to be the mic.
Yes, better.
So I guess to that hypothesis is when I wanted to add a little more of salt in it. So when you have
I agree with the hypothesis first, because actually you start in a way to...
I don't know, I'm challenging it, but I don't know if it's, I like it. I like your hypothesis, I like it. Now, I'm a scientist, so I'm trained to challenge everything that I see or that I hear, which is great for my family and my, significant others. Anyway, so when you have binding thyroxine to transthyretin tetramer, that binding is also an equilibrium. So when you lower the concentration of transthyretin, that doesn't mean that the 10% is fully occupied. Maybe the ratio of occupied versus non-occupied remain similar because of the equilibrium between the binding. What do you think about that?
Actually, this calculation is not easy. We have the experience of calculating the occupancy of tafamidis to the first and the second site at the concentration. We made some nice calculation thanks to the help of physics, Alessandra Corazza, who made many calculations about. So it will be not easy, but you should also consider that some thyroxine is bound to albumin, because actually there is a degradation of affinity. You go with thyroxine binding globulin is 10 to minus 11. Then you go down to minus 9 for the first site of TTR, and then you go to minus 6 for albumin, that is in highest concentration. So the exact distribution is probably, but for certain, the homeostasis, thyroxine binding globulin should be covered. Then the additional, because you should consider why low thyroxine in these patients. And so it means that transthyretin has a role. If he has a role, he has a space for binding some of the hormone. And nobody knows so far how much is occupied the first site. But the first site is not enough, in my view, but it can help.
We have to stop.
Yeah. I'm very sorry, but we start a little bit late, so we have to stop this very interesting in conversation. So let me thank both Julian and Vittorio for their discussion, also the audience that has participated. So we stop, and later I leave the floor to the next session. Thank you very much indeed.
Okay, just a couple of messages. If you're got a question, can you please stand up for us? The ladies are struggling to find you, so if you could stand up and wave, that would be really good. And just in case you don't know, there's some translation headsets outside that if you want to hear in a language you prefer. And also another message, we've got the exhibition area, which yesterday, we obviously as patients, we couldn't go to. But if you want to go and say hello during the day, that section's open to everybody now. Right then, should we make a start? I'm David Gregory, a trustee with the Amyloidosis UK and a board director with the Amyloid Alliance. I'm also a patient with early stage hereditary ATTR amyloidosis. I'd like to welcome you all to the first session of the joint program. And we're going to, this is a unique part of any congresses actually, that we actually have this day together. And we really do think it's something that is very special for this congress to learn and understand about this disease. I'm going to pass over to Marco Ligeti to introduce the next stage.
Thank you, David. We can now start this session about controversies and debates. An interesting question, how we monitor disease progression. It is my great pleasure to introduce again Professor Marianna Fontana, that will speak us about the use of guideline, pros and cons. Please, Marianna.
I'd like to thank the organizer for this invitation. It's my pleasure to speak especially about this topic, which I think is extremely relevant for us as clinicians treating patients and has been in really rapid evolution over the last 5 years. So I was supposed to have a debate with Pablo Garcia-Pavia, which I would have very much enjoyed, but unfortunately had to leave early. So I will just give a presentation on the topic. So when we think about guidelines for monitoring disease progression, so first of all, it's absolutely important to recognize that there are none. So none of the documents which are currently published, which discuss criteria for disease progression, are actually guidelines. So the first document that came along was this document from 2021, which was written by a group of academics and sponsored by pharma, and tried to summarize potential criteria for disease progression. But back then, this was an extremely difficult task because actually there was no published evidence on any of the criteria which now we use for disease progression. So back then, this group of experts came up with 3 groups of criteria, so clinical and functional, laboratory biomarkers, and imaging and ECG. And they also established that one marker from each domain provides the minimum requirement for assessing ATTR disease progression in ATTR cardiomyopathy. But let's review one of each of these domains. So what happened in the last 5 years is that there has been a lot of research and data coming out on trying to establish what can we use in clinical practice in terms of establishing disease progression, and so what is the change over the course of 6 and 12 months which are clinically meaningful, i.e. associated with worse prognosis in our patients. When we look at the group of clinical and functional domain, they proposed heart failure hospitalization, worsening NYHA class, worsening the quality of life, and worsening 6-minute walking test. So heart failure hospitalization definitely is one of the criteria that stayed, as we know that heart failure hospitalization is probably the single most important occurrence in the lifetime of our patients. We know that mostly our patients are stable until they get the first heart failure hospitalization, which really are signals of a change in the disease course and prognosis of our patients. Worsening in NYHA class, several people have demonstrated that is strongly associated with prognosis, not only a baseline, but actually a follow-up. So this is definitely something we can look at. But what about worsening in the quality of life? So we are not really used about using quality of life metrics in clinical practice, although this is something that we absolutely have to implement. How patients feel and what really matters for them, which is quality of life, is something that we should have an obligation to measure systematically in all patients. But what's the evidence for a change in the quality of life in ATTR-CM? There is no much evidence on ATTR-CM about the specific cutoff that we can use, but from heart failure we know that a change in 5 points is strongly associated with outcome and is modified by treatment. And this is what we've been using also in patients with ATTR-CM. But what about the functional capacity? A large study from the NAC of more than 2,000 patients showed that a change in the 6-minute walking test of more than 35 meters over the course of a year is strongly associated with overall mortality and also modified by treatment. But there is an additional criteria within this domain which was not in the original publication, but which has been demonstrated to be extremely important in our patients. So when we think about heart failure, patients with heart failure do present with heart failure hospitalization, and we know that that's extremely important. But what happens before? Can we measure worsening of heart failure in the outpatient settings? And what this paper established, that increase in the diuretics, which was driven just by clinical judgment, is a strong independent prognostic predictor in our patients. And why is that? Because when heart failure worsens, what we do as clinicians is that we increase the amount of loop diuretics. So actually the increase in loop diuretics or starting new diuretics directly correlate with worsening heart failure in the outpatient settings. And so this enables us to publish, to capture something that we weren't able to capture before. But what about the second domain, laboratory markers? Again, a lot of work in the last 5 years. There's a large study that established that an increase in 700 nanogram per liter associated with an increase of 30% from baseline is strongly associated with prognosis. And why do we need both? Because if we have a patient with very low NT-proBNP like 300, a 30% increase might not be clinically meaningful. And that's also why we need also the 700 increase. But on the other side of the spectrum, when we have a patient with very elevated NT-proBNP value like 20,000, 700 increase is not really good enough. And so we need to have also 30%. So the association between 700 and 30% is what allows to make NT-proBNP cutoff a robust marker across the wide spectrum of patients with ATTR cardiomyopathy. Ultrasensitive troponin, increase in ultrasensitive troponin T of 15 nanogram per liter at 12 months, again, strongly associated with prognosis. Can we use that in clinical practice? Yes, we can, but obviously there are lots of differences in different assays, and that is one of the things that probably limit the use of these troponin T or troponin in clinical practice. Next stage, so combination of GFR and NT-proBNP, strongly associated with prognosis at diagnosis and follow-up, and is definitely modified by treatment. And more recently, we have also learned to follow the eGFR, so a decrease of more than 20% from baseline in a large cohort of patients with ATTR cardiomyopathy, again, is strongly associated with prognosis. But what about the last domain? In the imaging domain, there was mention of increasing the wall thickness, decreasing the ejection fraction, decreasing the GLS, decreasing the stroke volume. Actually, none of the markers that were mentioned in that document has survived the data that have come out lately. And when we think about echocardiography, whilst we do in every single patient in clinic, the only parameters by echo that help us to define if the patient is better or worse are worsening in mitral and tricuspid regurgitation and possibly stroke volume. So this is definitely the domain where things are very dramatically different from the original document that tried to summarize the criteria. So when we go back to the document in clinical and functional, They were all confirmed, but actually the 6-minute walking test with a different cutoff, and also we learned the importance of assessing also the diuretic increase or initiation in terms of loop diuretics. In terms of laboratory domain, yes, we have NT-proBNP, troponin, and eGFR, but now we have very established and validated cutoff that we can use. And in terms of imaging, as I mentioned, increasing wall thickness, diastolic function, ejection fraction, GLS, none of these parameters is actually useful to assess progression over time, and only worsening in MRTR and stroke volume have been proven to be useful. But lately also we have seen how CMR with T1 mapping and ECV mapping, which measure the cardiac amyloid burden, is strongly associated with prognosis. So a change in ECV over 12 months or more than 5% has been strongly associated with prognosis. Also, what we haven't fully established is how many of these markers do we need to use in combinations, and we know also that there is an interaction between these markers. Increasing diuretics will affect the NT-proBNP, will affect the functional capacity, will affect the quality of life, and so we need to understand how to take a holistic approach and actually assess the complexity of progression in these patients. But let's take a step back and think about, okay, we see a patient in clinic over 12 months, so we can tick all the boxes and say, yes, the patients have progressed on the 6-minute walking test, functional capacity, quality of life. But what can we do about it? In the sense, how does that change affect what we do in terms of management strategies? What is wrong with what we have, even when we think about these newly kind of defined markers of disease progression? The big problem is that they are extremely indirect. They capture downstream effects, and they don't capture amyloid biology. So they are non-specific, so they miss key disease pathways. And also the second problem is that they are not targeted linked. And this means that they are not aligned with therapeutic mechanisms. So going back to the basic mechanism of pathophysiology, so what does drive disease progression in ATTR cardiomyopathy? Definitely we have the new production. We know that new production is one of the main drivers. And now we can target this mechanism with silence stabilizers and potential genome editing. We do have also progression because of the existing deposits. So we know that if we have a patient with very advanced amyloid infiltration, even if we completely stop the new amyloid production, that patient will progress because of the existing deposits. And thirdly, in every patient, we've got also the activation of the standard pathways that we see activated in heart failure. So every patient with heart failure, we've got sympathetic activation, parasympathetic deactivations, and these are independent drivers of disease progression. So, but how do we track these three main mechanisms? None of the markers that I've shown you before track none of these mechanisms. And the problem is because they track downstream pathways and they do not reflect specific mechanism that we can target with treatment. There is a dissociation between how we track disease progression and how we can action tracking disease progression with treatment. But what can we do about that? When we think about progression, probably the most promising markers in terms of future perspectives is the TTR levels. We've seen how we can follow the TTR levels with silencers. We have seen how we can follow the TTR levels even with stabilizers, where an increase in the TTR levels with treatment has been strongly associated with outcome. And what we really need actionable cutoff to then advise on treatment strategies. But what about the mechanism related to the existing amyloid deposits? What we need to measure the amyloid load, because once we will have depleters, we will have to titrate the treatment with depleters to the existing amyloid load in every single patient. When we think about weight management strategies, none of us would think to apply the same management loose kind of weight strategies in a patient with a BMI of 40 or with a BMI of 27. And so why should we use the same depleters in a patient with a severe amyloid load or only mild amyloid load? And thirdly, we need to keep in mind that the standard heart failure pathway of neurohormone activations are activated also in these patients. So we have to optimize heart failure treatment in every single patient. And so going back to how we track disease progression, what do we want from markers of disease progression? So these are all the steps that we need to kind of validate when we think about developing a marker of disease progression. We start from basic level. We want that our markers tell the difference between the health and disease. We want that our marker follows specific pathways, so it's able to have high sensitivity and specificity to actually diagnose the disease. Then we need to show that the marker can track changes over time, i.e. that the changes that biomarker is linked with the prognosis. Then we need to make sure that that link with prognosis remains also after started treatment. But what we need to bear in mind that ultimately what we want from any biomarker of disease progression is track the changes over time, track the changes with treatment, and then guide treatment strategies. And by guiding treatment strategies with that specific biomarker, we need to be able that we improve the patient prognosis. And we have a beautiful example of that in cardiology. So in the 60s and 70s, in patients with thalassemia, so patients that were dying of cardiac iron overload, we started to have chelation therapy. And so with chelation therapy, what we could do, we could remove the cardiac iron overload, and we knew that the cardiac iron overload was the main driver of prognosis. And what you can see is that between 1970s and 1980s, there was a bit of an improvement, and that's because the chelation therapy came along, so we had something that we could treat our patients with. But you can also see that there was only a marginal increase between the 1980s and 1990s. And then you see a massive improvement in prognosis in the 2000s. So what happened there? So the only thing that happened there is that T2-star came along. So T2-star is a technique by CMR using cardiovascular magnetic resonance that can measure the cardiac iron overload. So what happened is that by being able to measure the cardiac iron overload, we were able to titrate the chelation therapy in every single patient to the extent that every single patient needed. So we were able to give high chelation therapy to patients with severe iron overload, low chelation therapy to patients with low iron overload, but we were able to treat the patient for as long as each patient needed to get them to a low iron overload, and we knew that at that point the patient's prognosis was much better. So T2-star is a beautiful example of how having good treatment is not good enough, but actually having markers of disease progression which are tightly linked to the treatment and guide treatment strategy can directly change prognosis of our patients. So we are definitely not there in amyloid, but we have seen extremely promising markers like the TTR levels for silence stabilizes genome editing, CMR with extracellular volume to measure the amyloid load for depleters that hopefully in the future will enable us to guide the treatment strategies and improve then the patient's prognosis. Thank you very much for the attention.
Okay, we've got some opportunities for questions. If you do want to ask a question, if you could stand up, just to help the ladies find you. What we'll do is we'll start with the next presentation, and then we can have questions at the end. So if you have to think about that.
So we move to following presentation. It's my pleasure to introduce Professor Nienhuis. I hope to correct pronounce the surname, that will speak us about patient-reported outcome measure. Where is? It's online, okay.
Yes, good morning. and thank you for the introduction. And thank you for the opportunity to present during this wonderful meeting. I would have loved to be in Baveno in person, but my wife is about to give birth. And I did not dare to travel to Baveno at this stage. So by tomorrow I will know whether I made the right decision. And I will discuss where we stand with patient-reported outcome measures, the tools we have, the gaps that remain, and also how I think we can move forward. Dus, can you all see my presentation? Okay. So these are my disclosures, and this is the outline of my presentation.
We have not seen your presentation, Hans.
Okay, I will try to fix that.
So we're looking for the presentation. Have you got that over there, guys?
Screen, I think it's over there.
It
and
is
then
here.
I have to click over here. Do you now see the full screen?
Perfect.
Okay, great. Yeah, so we are going to discuss patient-reported outcomes measures. And these are my disclosures. And this is the outline of my talk. I will start by explaining what patient-reported outcome measures are and why they are especially important in ATTR amyloidosis. And next we will review the prompts currently in use in ATTR amyloidosis, and then I will discuss prompts that are specifically being developed for ATTR amyloidosis. And after that I will discuss considerations for using prompts in ATTR trials and clinical practice, along with current gaps and challenges. And finally, I will outline some limitations and cautions when using prompts before concluding. But before we dive in, let's first define what we mean by patient-reported outcome measures. Prompts. Prompts are tools such as questionnaires, surveys, skills that capture outcomes directly from the patient's perspective. And they assess symptoms, daily functioning, quality of life, emotional well-being. And they are complementary to clinician-measured outcomes like lab tests, imaging, and functional assays. So why are they important? Well, they reflect, or at least they are supposed to reflect, what truly matters most to the patient. They allow us to track changes over time, to evaluate the benefits of treatment beyond functional assays, labs, and scans, and so on, and to support more meaningful shared decision-making between patients and clinicians. So how does this translate to ATTR amyloidosis? Well, ATTR amyloidosis, as you all know, is a multi-system disease. Organ-specific outcome measures may fail to capture the total or combined burden of the disease. And that's why assessing disease burden and treatment benefit has to go beyond just measuring organ damage or disease progression in the heart or nerves. The goal of therapy is not only to slow or stop the disease, but also to preserve and, when possible, improve quality of life and daily functioning. And this is also increasingly being recognized by health authorities and regulators who are placing more weight on trial endpoints that show meaningful patient benefits. So in this context, prompts become especially valuable. They allow us to track disease progression from the patient's perspective, tailor supportive care to individual needs, and evaluate the impact of intervention, not just drugs therapies, but also the full spectrum of care. So what tools are currently being used? First, there are general health status tools, such as the 36-item short form survey, which consists of 8 domains, including physical functioning, role limitations, emotional well-being, and social functioning. And then there's also the Euro Quality of Life 5 dimensions questionnaire, which, as the name suggests, consists of 5 dimensions: mobility, self-care, pain, usual activities, and anxiety and depression. And these prompts provide a broad overview of health-related quality of life. And in addition, manifestation-specific tools are applied. The rash-built overall disability scale focuses on disability related to neuropathy. The Composite Autonomic Symptom Scale 31 questionnaire assesses autonomic symptoms. The Norfolk Quality of Life Diabetic Neuropathy questionnaire captures neuropathy-related quality of life. And the Kansas City Cardiomyopathy questionnaire evaluates the impact of heart failure symptoms. So let's look at some evidence on how these prompts have been used in ATTR amyloidosis. And these are just some examples. The Nordic PRO-X study, which included 169 patients with ATTR cardiomyopathy, used several measures like the KCCQ, the AQ5D, and the Major Depression Inventory. And they reported low mean KCCQ and AQ5D scores compared to those previously observed in non-ATTR heart failure patients. And importantly, quality of life was significantly worse in more advanced NIA class or NAC stage. So these prompts correspond to parameters of disease severity. Another study shown to the right showed that prompts themselves can predict outcomes. In a prospective ATTR cardiomyopathy cohort from Vienna, the AQ5D and the KCCQ and the Minnesota Living with Heart Failure questionnaire were used to assess health-related quality of life. And the AQ5D FAS and the Minnesota questionnaire were found to be independent predictors of mortality in ATTR cardiomyopathy. And it's interesting, it made me wonder, shouldn't we validate these scores to use them more often to make treatment decisions? For example, tafamidis treatment decision is now based on NIA stage, at least in the Netherlands. And maybe these prompts give more balanced information concerning which patients may benefit a treatment and which patients not. Should be investigated. But these, in clinical trials of ATTR cardiomyopathy, the Kansas City Cardiomyopathy Questionnaire is frequently used to assess quality of life. And I show here some of these trials. And across these trials, which all show improved survival, patients on active treatment consistently had better preservation of quality of life compared to those on placebo. And for ATTR polyneuropathy, the Norfolk Quality of Life Diabetic Neuropathy score is commonly used. And these trials demonstrated a slower decline and in some cases even improvement in the quality of life, along with favorable outcomes in other clinical parameters. So prompts in both observational studies and clinical trials clearly provide valuable insights. And the results align with other clinical outcomes, and most of them are well validated. However, it's important to note that the tools mentioned were not developed specifically for ATTR. They were adapted from other conditions, and they only cover parts of the overall disease burden. For example, some patients with ATTR cardiomyopathy are not that much limited in daily life by heart failure symptoms, but more due to pain in their legs or back, due to osteoarthritis or spinal canal stenosis. And in some patients with hereditary ATTR amyloidosis, it's not the cardiomyopathy or the neuropathy or the peripheral neuropathy that impacts quality of life the most, but it's rather the gastrointestinal involvement or the eye problems, or in rare cases, the cerebral involvement. The fact that these generic or adapted prompts do not fully capture the disease burden in ATTR amyloidosis has also been recognized by several colleagues who have developed ATTR-specific prompts. And I'd like to discuss some of these. So the ATTR Quality of Life questionnaire was developed using a conceptual model that was based on a literature review and involved direct input from both patients and clinicians. And it captures two main domains: the symptoms domain, including cardiac, peripheral, and autonomic, neuropathic, and other symptoms, and the impacts domain, which includes physical functioning, role activities, and emotional or mental health. And originally, it consisted of 72 items, 32 assessing symptoms and 40 assessing impacts. But recently, validation for the impact scales was conducted, leading to a refinement in the item structure and confirming validity, internal consistency, test and retest reliability, and the validation of the symptomatic domain, the symptoms domain, is ongoing. The recall period for this questionnaire is 1 month. The recall period is the time frame over which patients are asked to report their symptoms, such as the past week, or in this case, the past month. Then there is the ATTR patient symptom survey. This was developed through literature review again, and also with input from clinicians and patients. And it was revised after evaluation by a patient focus group. And the survey is designed to be applicable to both wild type and hereditary ATTR amyloidosis, and covers cardiac as well as neuropathic manifestations, and captures information about symptom type, frequency, severity, and the impact of these symptoms. It includes 32 symptoms along with 12 additional diagnoses or complications, and has a recall period of 1 month. And the content validity was confirmed through interviews with patients and clinicians. And then the last ATTR-specific prompts that I would like to discuss are those developed through the impact of transthyretin amyloidosis on life quality, the Italy study. 2 30-item questionnaires specifically designed for patients with wild-type and hereditary ATTR cardiac amyloidosis were developed, again, based on literature review and input from clinicians and patients. And each questionnaire offers 5 response options. And the validation was conducted in a multi-center Italian cohort. In terms of feasibility, only 30% of patients required assistance to complete the questionnaire, which took approximately 10 minutes. And the Italy study scores demonstrated a strong correlation with established non-ATTR specific quality of life measures, such as the KCCQ and the SF36. So ATTR specific prompts have been developed, but there are still gaps that remain, and we will discuss these soon. But first, I would like to share some considerations when using prompts in clinical trials or implementing prompts in clinical practice. And again, the list I'm going to show is not exhaustive. So considerations: first, selecting the right tool or tools is essential. For patients with predominantly cardiac symptoms, it's best to use prompts that focus on heart failure domains. But for those with neuropathy dominant disease, neuropathy-specific tools should be included. And for mixed phenotype, and I actually believe that most patients with ATTR amyloidosis have more or less a mixed phenotype, a combination of tools or broader questionnaires may be necessary. And next, think about the recall period. Of course, this is already determined based on which PROM you choose, but a recall period that's too long can introduce recall bias and affect accuracy. Also consider the frequency of measurement. How often will you administer the PROM? This might be at baseline, of course, and then during follow-up every 3 months or every 6 months. If the frequency is too low, that may impact the reliability. If it's too often, that of course impacts the burden on the patient. The mode of administration is another key factor. Will the questionnaire be completed on paper or electronically, by telephone or during clinical visits or remotely, with assistance or without assistance? All these things may introduce some kind of bias, so this should also be considered. Accessibility in terms of language and cultural adaptations is important as well. Ensure that translations and cultural adaptations of prompts are properly validated before use. And psychometric properties of the tools should be evaluated, including the reliability, the validity, the responsiveness, and the minimal clinically important difference. So which change in the score is really meaningful. And finally, reduce patient burden by balancing the comprehensiveness with questionnaire length, avoiding overlapping questions and prioritizing the most relevant domains. So, despite the progress in patient-reported outcome measures, several key challenges remain. First, mixed phenotypes. Just using separate tools for each disease manifestation not only increases the burden on the patient, but it also may overlook important interactions between symptoms. And I think ATTR-specific prompts may address this gap. Second, many tools suffer from ceiling or floor effects, along with limited sensitivity to detect meaningful change. So ceiling and floor effects occur when many respondents score at the extreme high or low end of a scale, and that limits the tool's ability to detect improvement or a worsening. And this is particularly problematic in longitudinal studies where we need to establish both responsiveness and the minimal clinically important difference. And from the patient's point of view, there's a growing need for shorter and more flexible tools that don't take up too much time, but still give good information. And another thing is that we need to understand whether prompts can predict hard clinical outcomes, such as mortality or hospitalization, and whether they can be effectively integrated into prognostic models. It's also important to adapt and translate these tools carefully so they work well across different cultures and languages, making sure results can be compared worldwide. And another big challenge is adding these tools into electronic health records and daily clinical work, so doctors can easily use the information to help patients. To address current gaps, I would suggest using newly developed ATTR-specific prompts alongside the generic health-related quality of life tools such as the AQ5D or the SF36 in clinical trials. And this way we can capture details specific to ATTR while also being able to compare the results with other diseases. A key priority, I think, is to define minimal clinically important differences for these ATTR-specific tools within our own patient populations. And studies to establish the minimal clinically important differences could be embedded as sub-studies within larger trials. And prompts shouldn't be limited to research. They should also be incorporated into routine clinical care to help guide supportive care strategies. And finally, we need to work together to validate these tools across different languages and cultural contexts. So there are, of course, also limitations. Prompts are subjective. Responses can be influenced by mood, expectations, or current or recent events, and they depend on the patient's literacy or cognitive function and capacity to respond. Missing data or drop out over time can bias the results, and disease heterogeneity, what is meaningful in one patient may be less meaningful to another patient, and that's also something to keep in mind. Cultural differences in the interpretation of items, and also be careful in interpreting small changes unless we know the MCID, the minimal critical identifiable difference. Sorry. So that brings me to my conclusions. ATTR amyloidosis imposes a heavy burden across multiple domains: physical, functional, and emotional. Prompts are important tools to capture patients' experience, assess treatment benefit, and guide care. And while generic and borrowed tools have been useful, there has been a gap in comprehensiveness and specificity, and the development of ATTR-specific tools like the ATTR quality of life, the ATTR Italy score, and the ATTR PSS represents a major step forward, I think. Still needed is longitudinal validation, determining the MCID, tools balancing between comprehensiveness with usability, and integration into both trials and routine clinical practice. I think prompts can really help to offer holistic care to our patients. Thank you for your attention, and I'm happy to answer questions.
Okay, we've got some time for discussion or comments or questions. We've got one over here. this person standing at the front here.
Thanks. Great session, as always. I'm slightly concerned because we're getting busier and busier in clinic, and I'm trying to work out how often am I going to need to see my patient with ATTR cardiomyopathy, and is 12 months too long to wait? So my question really is, how long do you wait to decide whether a treatment's working, and could PROMS be the answer to that? Perhaps we don't need to see the patient in clinic. You know, the trials have all shown the earliest separation has been in KCCQ, so would a reduction in KCCQ be enough, and if so, at what time?
Yes, thank you for this question. I think it's a difficult to answer question. I feel that this is also something that's really difficult in clinical practice, because first of all, the treatments we give retard disease progression, or at best stop disease progression. So under treatment, if a patient is progressing, is the treatment then not working? That's difficult to determine. And of course, I think PROMS could be helpful along with other markers of disease progression. But we really need to establish when you can decide that the disease is progressing and when not, and when the treatment is effective and when not, and that's very difficult. And the other thing is that, indeed, how often do you have to monitor your patients? We used to have a phone call after 6 months with a treatment started with an ATTR cardiomyopathy patient started on treatment, and then we have a clinic visit after a year. And I think what's most important is the clinical condition more or less stable. That's what I try to quantify. And how's the quality of life? And sometimes patients during the phone call or during the visits tell me that they experience a very low quality of life, and that can be a reason to stop treatment. But indeed also the frequency of follow-up, I don't have an answer what's the best time frame. And of course, with introducing PROMS and all other things we want to measure, it becomes quite complicated. But hopefully in future also apps or online tools can help to patients to provide this information, so it becomes easier to collect all these things and to monitor patients remotely, for example.
I'd like to say something about definition of progresses and no response to therapy, because I think these are two different concepts. In the sense, when we think about the markers of disease progression that we have at present, like we talked about the clinical one, the biomarkers, none of them are specific for the treatment we give when we think about disease-modifying treatment. So let's say we see a patient in the UK, we have only tafamidis, so we start tafamidis at baseline. At 12 months, we see the patient is worse in terms of KCCQ, functional capacity, and NT-proBNP. Can we really say that that patient is not responding to tafamidis? I'm not sure we can, because as I tried to kind of explain before, there are different mechanisms which contribute to disease progression in these patients. It could just be that the heart failure has gone worse. We are not able to use many of the heart failure medications, so we are not able to fully block all the axis and neurohormone activation that we would do in standard heart failure patients. Or it could simply be that the patients have got an extracellular volume of 60, so he started from a severe amyloid load, so the main driver of disease progression in that patient could actually be the existing amyloid deposits. So in that patient where the functional capacity is worsening, the KCCQ is worsening, and the patient is on tafamidis, I cannot use those to say, oh, the patient is a non-responder to that specific medications. And that's why we need to switch from criteria of progression, which are extremely valid for us as clinicians to understand the direction that the patient is going, because it's extremely important to know if the patient is stable or actually prognostically is getting worse. But we need to dissociate that from markers of treatment response. And that's where I see a much more prominent role of TTR levels for silencers and stabilizers, and imaging, a present CMR with ECV mapping for depleters. And as I mentioned, for me, the T2 star in thalassemia patients is a beautiful example of how it's not just important to have the right drugs, but it's important to have specific markers which define response to treatment. We are not there yet in amyloidosis, but definitely we've seen during the last couple of days how promising these markers are in terms of future use.
Other question? We have time for another couple of quick questions and quick answer, of course.
Yes. So first of all, I want to say this is fantastic to have a talk about quality of life tools. I would just say that the ATTR-QOL is actually translated and culturally validated into 23 languages. I think one of the most important things, and we've heard a lot about progression and what that looks like, but to really recognize the burden of disease that many patients, even if we stabilize their disease, suffer from, and the critical role of biomarkers, as well as the importance of validating PROs so that they can be used in the next generation of clinical trials. Because otherwise, I think with hard endpoints as we currently have, we won't be able to advance the development. Thank you.
We've got one more question just down here at the front. Gentlemen, they're just coming over, Rapid.
Well, I must admit I don't know too much about ATTR, but I think you can easily follow if the silencer works because you see less transthyretin. Can you follow the stabilizer, how it works? Do you see less something else in the blood?
I mean, I'm not saying that we are ready to use it now in clinical practice, because definitely there is much more work to do, also in terms of understanding which assays are the correct ones and which assays are not the correct ones. But at the same time, we have evidence building up from clinical trials of patients on stabilizers that if we measure as early as 28 days, the TTR levels, that increase is associated with better prognosis. So I don't think that we are ready yet to start tomorrow to use that in clinical practice, but if I have to think about what biomarkers are closer to become biomarkers which define response to treatment, for me is really TTR levels for drugs which switch the new amyloid production, so stabilizers, silencers, genome editing, and then imaging that measures cardiac amyloid load for the depleters. So we are not ready yet, but I really strongly believe that the evidence is building up so rapidly that in a couple of years, that could be our main factor to decide what to do with the treatment. Of course, that doesn't mean that everything else we do is not important, and I completely agree on the comment on the importance of assessing holistically the progression. The KCCQ, we should do it in every single clinic, or other measures of quality of life. But when we think about then actioning in terms of specifically linking the response to the treatment, I think that the most promising markers are definitely TTR levels and then imaging for the amyloid load.
Okay, thank you, Marianna, Hans, for that. Well, we've got one more.
Very, very quick.
Last question for Marianna. I'm a CMR passionate like you, and I'm quite puzzled at the use of the extracellular volume assessment to track the disease progression. I learned from your study that you can use the limit of 5% to assess the disease progression, and I wonder if 5% of ECV volume increase or decrease could be a very low value in terms of, so considering also the limitation of ACB assessment, you know, so it's quite limited in terms of ROI assessment, hematocrit, dosage, administration, and time from administration and acquisition of post-mapping. So this is my...
Yeah. Thank you. And I completely agree that there is a lot of work in terms of standardization of the technique that has to be done for extracellular volume to be used in clinical practice to guide treatment strategies. But again, if we look at the last 25 years of research in T2 star, we went through exactly the same. At the beginning, T2 star was not something easy to do. It was quite complex. We had to draw a lot of regional interest, then fit the curve, derive the volumes and everything. And then when the utility of the technique was discovered, then everything now is automatically done on the scanner and on the software, and actually is really as simple as drawing a single regional interest. So whilst I completely agree that there is, again, even for ECV, a long way to go to standardize the acquisitions and measurement to be used in clinical practice, I do not believe that is an impossible kind of pathway to go through. And fundamentally, I cannot understand how we think of using antibodies which trigger an immune response, macrophage response, systemic reactions, AEs, without being guided by even just how much the load is a baseline. I mean, we would never treat with the same weight management strategies a patient whose BMI is 45 or one which is 26. So why should we do the same? Shouldn't we do the same in amyloid? So the path is not a simple one, but I think standardization can happen. And I absolutely agree with you that there is work to do.
Okay, thank you, Marianna and Hans, for a great presentation. Thank you. I'd like to give them a clap.
Thank you. Hello, my name is Agnès Farrugia. I'm the past director of the Amyloidosis Alliance, and I'm pleased to moderate this session.
Hello, my name is Simone Longhi. I'm a cardiologist in Bologna University. It's a great pleasure to be here today. So we can start with the next section. Symptomatic management of ATTR amyloidosis. It's a pleasure for me to introduce the first speaker. Ricardo, Pereira and Silva from Lisbon, Portugal, who talk about the urologic aspect of the disease. Thank you.
Can you hear me? Oh, yes. It's a pleasure to be here at this meeting among the greatest experts in this field. I'm a urologist, so a little bit awkward. And I feel like this, so I'll try to make a good work today. Seems kind of tricky. We talked a lot about quality of life, and usually urinary symptoms are about quality of life and sometimes about having a safe upper urinary tract, as we'll see after. In Portugal, we have some incidents of amyloidosis, the familial type. We had this study by Maria João Andrade, a rehabilitation doctor, and she conducted this study with 54 patients, 28 females and 26 males. In urology, it is very different males from females, so we have more differences and we have more into account when phenotyping the patients. And when we look at the symptoms, so the symptom usually it's not the same as the dysfunction. So it's different to have the dysfunction or to have the symptom. And the first urinary symptom, sometimes it's difficulty to void. So this could be a late stage disease symptom because the patient feels like and reports an ability to void spontaneously in a normal way. So when we look at the symptoms, patients may be overactive in the beginning, so they may have an overactive bladder, they may have no urinary symptoms at all in the early stage of the disease, and in the late stage, there may be difficulty to void, there may be urinary retention, like it's a red flag to have urinary retention, and they may not fill their bladders at all, but this is like a broad spectrum from the beginning until the end, and we should be aware of that. And of course, there may be incontinence, sometimes it's overflow incontinence because of voiding dysfunction, and urinary tract infections that sometimes take the patient to the urologist or to their doctors to treat the infection, but the infection is only a manifestation of the voiding dysfunction. And of course, again, patients are very different. Men are different from women. Early stage, late stage, the kind of amyloidosis the patient has, the phenotypes are very different from patient to patient. And there are also many other risk factors involved in lower urinary tract symptoms and in lower urinary tract dysfunction independently from the symptoms. And so we should take all of this into account, like benign prostate hyperplasia and all the gynae and obstetric previous history, and the pelvic surgery, smoking, and all the lifestyle characteristics of the patients. So we should focus on screening the early stage disease. So sometimes a patient doesn't complain about something related to the urinary tract, but there is dysfunction. And when the patient reports some symptoms, we should try to phenotype the patient and understand which kind of dysfunction we're dealing with. When we look into the urinary tract, we have the storage function, we have the voiding function, and we have the upper urinary tract. Of course, the upper urinary tract is very important in the neurogenic patients, but also usually it's a late stage manifestation. So we should look into the storage first, because the storage is the first thing that may be impacted by the disease. So patients with amyloidosis may show storage dysfunction, meaning overactive bladder symptoms like going to the toilet too frequently or feeling like an urge to pee. It's in the first stage of the disease. We should use bladder diaries, and we talked about patient-reported outcome measures today, so this is like a very important tool, the bladder diary, because it's simple, it's free, and it's daily life information that you cannot obtain from office-based exams. So the patient can do the bladder diary him or herself, and or with the help of or a caregiver if necessary. And it's suitable for patients that already perform intermittent self-catheterization, because we can check on the volumes the patient shows, and we can check on the bladder capacity in their daily life, not just urodynamic or by invasive methods. It's still underused, unfortunately, and it should be used early in the assessing of the patient from the urinary point of view. This is the example of the ICQ bladder diary. This is a validated tool, again, because it was validated for a population in English. And you see that you have a lot of information here, like you have the amount of drinks and the type of drinks, you have the urine output in mils, and you have the bladder sensation. This is a very, very important field, because we have this scale on the left side, where the patient can write down what the patient feels when he needs or he goes to void. And so if you're very aware of this, and if it's like a neurourology appointment for patients with amyloidosis, probably you'll be able to, in a very, very early stage, to start detecting some abnormalities in the urinary function. Of course, in different countries you should have validated tools. So we did this in Portugal. So we validated the bladder diary in Portuguese and and culturally adapted it. And now we have this validated tool, which is very important, but it's available also in many, many other languages countries. About the voiding function, again, we have very, very simple exams that we may and we should use. The bladder ultrasound is of paramount importance because we can see if there's detrusor thickness increase. So if you have a thickened detrusor, again, it's not a late stage sign, but probably it's not a very early sign because it seems that there are already changes in the walls of the bladder. So it is, you should expect some dysfunction or symptoms because the bladder wall is not normal. You can have diverticular or bladder stones. It's not very usual in amyloidosis patient. And you could have elevated post-void residual, okay? So again, this is the failure of the voiding function of the bladder. If you have an elevated PVR, it means that the bladder is not emptying correctly or completely already. And so probably we missed an earlier opportunity to change something. And overflow incontinence, that you can see or you can assume that the patient has overflow incontinence if you have very, very, very high PVR. So if the patient voids and has like 500 mils PVR and the patient is incontinent, so probably that patient has overflow incontinence, okay? Showing very poor voiding function. Whenever possible, you should do a uroflowmetry because it's not just the volume, but the shape of the curve. If you see like a normal uroflowmetry, it's very different from these abnormal ones when the patient strains to try to get the urine out. And it's harder, of course, for men than for women. About the upper tract, unfortunately, nowadays we still see some patients developing upper tract deterioration, like having hydronephrosis or renal damage. We shouldn't have that, and we should try to prevent all of this much, much earlier than when the patient shows like high creatinine levels or hydronephrosis in an ultrasound. Probably we failed, or the patient failed to use our tools and our plan. But of course, this should be regularly performed, the ultrasound. All the clinical history taking, the physical exam, and treating all the comorbidities in women. It's very, very common to have in older women vaginal atrophy. There may be pelvic organ prolapse, and sometimes people treat the symptoms or the dysfunction, and very, very easy and straightforward diagnoses are missed somehow. And of course, in men, the prostate hyperplasia. We have a lot of tools, so it depends on the patient phenotype, and as was previously mentioned here, in amyloidosis patients, they are very different. They have different stages of the disease, and here is the same. Of course, we have lifestyle advice, we have bladder training, so try to sustain and not to go to the bathroom immediately if the patient feels the urge to go to the bathroom. But usually we have to do something to also treat this storage function. And we may use beta-3 agonists. Usually, mirabegron or vibegron are better than anticholinergics because they don't impact the voiding function. So we can treat the overbladder symptoms, the overactive bladder symptoms, without having a bad voiding related to anticholinergics. We also have the transcutaneous tibial nerve stimulation, which is a very nice treatment. It's very good for overactive bladder in an early stage. And then we can have sacral neuromodulation, but I will talk to that later on. About the voiding function, in men, always or almost always alpha blockers, because we can improve a little bit the voiding function, and eventually finasteride or dutasteride in men that have larger prostates, over 35-40 cc's. And of course, there's intermittent self-catheterization that many of our amyloidosis patients perform, but usually when they are in the later stage of the disease and are not able to void spontaneously, or if the voiding function is so impaired that they need to artificially empty the bladder at least once or twice a day. Another important thing is the prophylaxis of infections. We may use antibiotics, of course, but we are now trying to use antibiotic alternatives, and we have some that are very good and start having some literature about that in the neurogenic patients, such as this one, which is Uromune. And then we have the sacral neuromodulation again. So the main question here is that, can we change the natural history of the disease from a pelvic point of view? Can we try to improve the functioning of the urinary tract and change the way things are, or the things are going to be during the evolution of the patient? And we have sacral neuromodulation has been used more and more for neurogenic dysfunction of the lower urinary tract. This is a very, very broad umbrella, of course, because there are many different diseases. But these are the indications: so refractory overactive bladder with or without incontinence, and chronic non-obstructive urinary retention, so voiding dysfunction. Not related directly to obstruction like the one you see in BPH, for instance, or in stenosis of the urethra. And then you have fecal incontinence, which is a very, very good indication also. And you have chronic pelvic pain, like a secondary indication for this. You should always perform urodynamic first. And so here we place an electrode in S3 foramen, so near the root of S3. And we do it usually under local, but there are differences between countries and centers. We do it under local to check for the sensitive response. And then we use fluoroscopy to check whether we are in the correct place. Then we test this in the OR, so with the patient awake. We test this to check whether the sensation of the simulation is in the correct place, like in the bladder, anus, penis or scrotum, so midline structures. And if we see the motor response, which is the flexion of the toe or the contraction of the anal zone. This is the electrode. It's a quadripolar electrode, so 4 poles. And nowadays, we are able to do the reprogramming in an office-based appointment. So this is a very good option, maybe a good option. This is the test phase. We use a temporary generator outside of the body to check for 2 to 4 weeks. And then if if we have a positive test phase, we use the implant. And this, very, very briefly, because I'm running out of time, these are our results. This is unpublished data still, a very, very small series, but very specific. Usually more in males because of the voiding dysfunction being worse. Can we return? Yes. Because of the voiding dysfunction being worse, okay. 6 males, 1 female, age of the implant, 47, around 47 years, so probably a little bit late. And we have a good reduction in the PVR, pre and post implant. And if you use this scale, we should have this scale here up to 7. So the higher the number, the worse the response. So we have a light to moderate response here, around 3, which seems adequate. But we see this, the older the patient, the worse the response. So it seems like if we act a little bit sooner, maybe we can have better response from neuromodulation. And we see an increase in bladder sensitivity in our patients. We see some normalization of the flowmetry, so the patient starts to void more naturally than before. We see an increase in spontaneous micturition and a lowering of the post-void residual, and eventually a decrease in the number of catheterizations, which of course is very good for a patient's quality of life. So probably we can all act a little bit sooner in amyloidosis patients. We do a lot of things. We have catheters, we have augmentation cystoplasties, we have autologous slings, but probably if we act a little bit sooner, we can be able to try to defer and try to avoid some of these more invasive strategies. Thank you.
Thank you for the relation. Questions?
Complimentary presentation, Marco Luigetti from Italy. Just a curiosity. Do you think the same approach with neuromodulation will be available for late onset patients that can have more severe somatic neuropathy and maybe other problems, so for example, obstructive prostatic hypertrophy? Because you treated very, very early onset patients in Portugal.
Yes, for which indication? I didn't understand.
In late onset patients that develop disease later than 60 years, and they can have other urinary problems as prostate hypertrophy and have a different kind of neuropathy, more affecting motor fiber.
We have implanted some, let's say, not very good candidates. Some of them like Cauda-Equina syndromes, and you see like diabetic patients, like late stage, and there is some response, but the way we see it is that if we implant the patients earlier, you have a very nice response. If you go too late, sometimes it's like the bladder doesn't feel like part of the body, you see, and it kind of loses all the connection with the superior areas of the nervous system. And so usually earlier is better, but we've seen very encouraging response to late stage disease patients sometimes, yes.
Thank you so much.
Thank you, Ricardo, for this wonderful lecture. Just do a comment for me. How about the influence of neurosacral stimulation on our diarrheas and fecal incontinence? Because our patients, as you know, are getting better and better in this field.
Yes, thank you for the question. It was a lot to try to fit in 15 minutes lecture, so you should invite me for next year, maybe. But fecal incontinence is one of the best indications for sacral neuromodulation. It's always easier for the patient to improve from the fecal incontinence than overactive bladder or urinary retention, which is much, much harder, and you need to go earlier. Usually the patient with the fecal incontinence has a very, very good response when you implant sacral neuromodulation in any indication, including amyloidosis, but others the same.
When the patient has some issue to empty the bladder and the treatment is usage of tube, is there a mean to reduce the residue, re-education or anything, avoiding surgery?
Well, when the patient is already under catheterization, because the patient needs catheterization, usually sacral neuromodulation may be the only way, in my humble opinion, to improve the voiding function. There is no non-surgical way to do it, because it's late stage urinary point of view speaking, but it's a late stage.
Thank you.
Hello. Thank you.
Okay, thank you.
Very much. And now I'm pleased to introduce Jonas Wixner from Sweden. And Jonas is responsible for the Swedish transthyretin amyloidosis register. And his main interest is nutritional and gastroenterology aspect of ATTR. Thank you, Jonas.
Thank you for having me. I'm a gastroenterologist, so I feel a bit like the urologist before me. But I'm going to give you 15 minutes of gastrointestinal symptoms in ATTR amyloidosis shortly before lunch. These are my disclosures. And the outline is this. We start with the GI symptoms and then look a bit on the consequences of these symptoms and how we can manage them. But first, an overview of the symptoms. This is the GI tract, which we usually divide into the upper and lower GI tract, according to the picture here. And if we move from top to bottom, start with the mouth. Dry mouth is quite a common problem in these patients, both because of the disease itself and also because of the medications used for treating the disease. Dysphagia is not very common, but can still be a problem. Problem swallowing, that is. from motility disturbances in the esophagus. Early satiety is quite common, usually due to gastroparesis, a slow gastric emptying. Also nausea and vomiting a bit later in the disease. Pain and bloating is not very often discussed, but also quite a common problem due to motility disturbances in the bowel, with a lot of gas and a big belly, so to speak. Then next stage is diarrhea, also from bowel motility disturbances, and usually constipation precedes the diarrhea due to a slow colon transit. And last but not least, fecal incontinence, as you just heard of, a very troublesome symptom, but luckily it's not very common, only in late stages of the disease. So how common is this? These are data from the TEOS registry, an international registry with over 1,200 patients, and divided into variant and wild type disease. So in variant disease, it's quite common. This is about 4 years after disease onset, and around 60% of our patients have any kind of GI symptom. Whereas for the wild type patient, it's not very common at all. But recently we've seen that also a wild type patient can suffer from autonomic dysfunction, so these symptoms should not be neglected either in these wild type patients. These are also THEOS data showing the most common symptoms, and weight loss is the most common reported symptom, not maybe a GI symptom, but still a symptom that can occur early with or without other symptoms. Then it's followed by early satiety and alternating diarrhea, constipation, or a pure constipation or pure diarrhea. And as I said, luckily fecal incontinence is the least common symptom, at least after 4 years of disease. So if left untreated, these symptoms increase with time. So after more than 10 years of disease, 75% of all patients have GI symptoms, according to these tau stays at least. If we look closer at the symptom evolution, the weight loss, as I said, is quite early in the disease, and we don't know actually what that is caused by, but maybe the patient has a poor appetite, a decreased appetite, making them eat less, or maybe they have an increased metabolism due to the disease itself, but we don't know for sure. And for the upper GI tract, early satiety is usually the first symptom, and then it's followed by nausea and later on vomiting. And for the lower GI tract, constipation, it's usually the first symptom that is then relieved by bursts of diarrhea, and later on continuous diarrhea, and lastly fecal incontinence. And of course these symptoms can also occur simultaneously, especially in late stage disease. So what are the consequences of these symptoms? They are of course associated with a reduced quality of life, especially fecal incontinence, and also nausea, diarrhea. But they also cause malnutrition, which we measure usually with modified BMI. And that in turn has been shown to be associated with a reduced survival both in untreated patients and patients treated with liver transplantation. And on the panel to the right you see a curve with the MBMI on the y-axis and the lifespan on the x-axis. So the lower the MBMI, the shorter the life expectancy of these untreated patients. And how should we manage this then? This is a flowchart from a publication some years ago showing how to investigate a patient with lower GI symptoms. And the main thing here is to exclude other causes of the symptoms like colorectal cancer, inflammatory bowel disease, infection, pancreatitis, celiac disease, and so on. So you should always think of other diseases causing the symptoms. Another way to look at it is this. If you have a patient with upper GI symptoms, you should at least perform a gastroscopy both to evaluate a slow gastric emptying and also to exclude other causes of the symptoms. And for patients with lower GI symptoms, you should do a colonoscopy to see if there are other causes of the diarrhea or constipation. And last but not least, the malnutrition should be evaluated with the modified body mass index, or at least weight at every visit. Let's go to the more specific management with drugs and diet. The main thing is, of course, to start an adequate disease-modifying treatment to prevent disease progression. And this has also been shown to improve the GI symptoms and also MBMI in some studies. So that's the main thing, of course. But you can also give dietary advice both to improve symptoms and to prevent malnutrition, and also symptomatic treatments are available. If we start with the diet, the general advice is to eat small but frequent meals, and also to chew the food well and have a drink to your meal. You should also avoid excess fat and sugars, and add some fibers to the food, and rather softer foods than hard or chewy food, so to speak. And you see here a nice serving suggestion with rice, fish and vegetables, and then a glass of juice to that. If you look at the specific symptoms, if the patient has upper GI symptoms, you should focus on small meals and soft foods. You should also chew the food well, of course, and reduce the fat content of the food, and also have a drink to the meal. If the patient has constipation, you should focus on adding fibers and fluids to the meal. And although we're in Italy, I'm afraid pizza is not a good choice if you have these kind of problems. Then if the patient has diarrhea or alternating diarrhea or constipation, you should focus on reducing the sugars or carbohydrates in the meal. You could also need to reduce the fat if low carbohydrate is not sufficient. But then on the other hand, it might be necessary to increase the protein content. You can also add probiotics if these measures are not sufficient. And as always, fast food is not good for you. If we look at the drugs, and I will go through this symptom by symptom, if you have dysphagia, this is mainly due to esophageal dysmotility, as I said, and maybe not a major clinical problem, but there are some treatments that you can try. There are no specific treatments, but you could try proton pump inhibitors to reduce the gastric acid, or calcium channel blockers or nitrates in some cases. Early satiety nausea is due to gastroparesis mostly. There you can try prokinetic drugs or motilin receptor agonists, and also proton pump inhibitors. But if the patient doesn't get better and have problems eating, a gastrostomy or gynostomy can be the only solution to be able to give enteral nutrition to the patient. Abnormal pain is also not so rare complication, usually due to motility disturbances of the bowel. And here you must treat the underlying cause, like the gastroparesis, the constipation, or the small intestinal bacterial overgrowth. And important to remember here is to avoid opioids and NSAID as painkillers due to their side effects, usually constipation and also gastric ulcers. Constipation, on the other hand, is due to slow colon transit, and here you use laxatives, as for any other patient with constipation, lactulose, polyethylene glycol, sodium picosulfate. You can also try the newer agents like linaclotide. Also here you should avoid opioids, since they reduce the colon transit time even more. But if the patient starts to have diarrhea, this is usually due to a small intestinal bacterial overgrowth, or SIBO. Here you can try bulking agents like psyllium seeds, or intermittent antibiotics like ciprofloxacin. But if the patient has severe diarrhea, sometimes it's necessary to give them continuous antibiotics like rifaximin. Same thing with continuous diarrhea, but it is often multifactorial. But you start with antidiarrheals like loperamide, and if that isn't enough, you can try cholestyramine if you suspect bile acid malabsorption, and also antibiotics if you suspect bacterial overgrowth. And in severe cases, you can try codeine phosphate or opium tincture as a next step. And last but not least, again, fecal incontinence, mostly seen in late stages, and often due to an anal sphincter dysfunction and in combination with diarrhea. And the main thing here is to treat the diarrhea with everything you got: antidiarrheals, antibiotics, cholestyramine, and opium tincture. But if this is not sufficient, you should consider a stoma surgery to make the patient handle the stool easier. And as we heard earlier, also this sacral neuromodulation can be an option in these patients with fecal incontinence. And finally, malnutrition is also usually seen in late stages due to both nausea and malabsorption. You should consider adding vitamin supplementation to these patients, especially vitamin D and calcium for osteoporosis prophylaxis. They can also need vitamin B12 and folate supplementation, and sometimes also magnesium. But in severe cases, enteral or parenteral nutrition can be necessary to treat the malnutrition. So to sum up, GI symptoms is common and early onset in ATTR-V amyloidosis, not so common in wild-type ATTR amyloidosis. They reduce quality of life, cause malnutrition, which reduces survival, but luckily they are treatable with both disease-modifying drugs, dietary advice, and symptomatic treatments. Thank you.
Thank you, Jonas. Do you have some questions for Jonas?
On one of your slides, there is mention to magnesium, complementary magnesium. Often a side effect of magnesium is diarrhea. So how can we prevent that?
Yeah, magnesium can cause diarrhea, that's correct. But usually it's not very severe diarrhea from the medication. So if you really need magnesium, you should give that. It can also be used to treat paresthesia or pain in the legs. So it's quite good, and it's not very much side effects from magnesium, I'd say. But you should be aware of the risk of diarrhea, of course.
Thank you.
Juan here from Spain, Juan González. How often do you see pancreatic exocrine insufficiency in your patients? And if seen, as we have seen some cases in our cohort, which mechanisms could be related to that in ATTR amyloidosis, if pancreatic synthesis could have a role there? Thank you.
So was it pancreatic? What, I missed the...
Exocrine insufficiency.
Yeah, pancreatic exocrine. We haven't seen that, we haven't investigated it either, I must admit, but of course it can be a problem as well. We know that the amyloid deposits in the pancreas, but you can always check the fecal elastase to investigate if there is an exocrine pancreas insufficiency. The symptoms are usually multifactorial, so you need to explore different mechanisms to be able to treat correctly. So endoscopy, lab samples, fecal samples is important to do so you can treat correctly. But pancreas is not a major problem, but can be.
Excusez-moi, ouais, c'est bon. Je vais compter sur toi, Agnès, pour traduire. Je suis infirmier, je suis là. Je ne suis pas assez à l'aise en anglais pour pouvoir vous poser les questions. Dans une de vos diapos, vous parliez de la sécheresse buccale. Et après, vous ne l'avez pas développé. Je voulais juste savoir si vous aviez des petits tips pour comment on peut améliorer ces symptômes-là.
Can you get that translated?
Stephen works in the reference centers in Paris of amyloidosis with typodamie, and is a nurse. And he asked how do you have some advice to give for dry mouth?
Dry mouth.
Yeah.
Yeah, there are some tablets you can use, or chewing gum, of course. I don't know of any specific treatments for dry mouth. We should always think of the other drugs you use, like painkillers and the anticholinergic medicines can also cause the dry mouth. So important to go through the medication the patient uses and also try to stimulate the saliva with tablets or chewing gum. Or, I don't know if anyone else uses anything else, but that's how we do it at least.
Alors, j'ai juste une deuxième question, j'en profite d'avoir le micro. Hier, on a vu qu'il y avait les régimes, les jeûnes intermittents 16-8 sur une journée, qui pouvaient réduire l'inflammation en accélérant un peu l'autophagie cellulaire. Je voulais juste savoir, est-ce que vous le préconisez, est-ce que vous en avez un avis là-dessus ou pas?
Tu peux répéter ta question, j'ai pas compris le début.
C'était par rapport au jeûne intermittent qui diminuait l'inflammation digestive et qui pouvait améliorer les symptômes digestifs comme la constipation et la diarrhée. Et je voulais savoir s'il avait un avis par rapport à ça ou pas.
Merci Steven, je ne sais pas dire jeûne intermittent en anglais. I will ask for a break.
So the idea is to, if the schemes in which you alternate lack of food with food assumption, 8-16, as it has been suggested, it may have an anti-inflammatory effect and stimulate autophagy, could have an impact also in the management of the symptoms.
Sorry, I missed the beginning there. Can you please repeat the question?
So, I mean, there is a lot of discussion generally about schemes in which you eat for 8 hours and you do not eat for 16 hours, okay? This is for general people, but they are wondering whether, as there is the claim that these schemes, nutritional schemes may reduce inflammation and promote autophagy, if this may play a role in our context.
I think that depends on the stage of the disease. If you're in the later stages, you need every nutrition you can get, so it's important to eat often, but small meals to get the energy and also to reduce the symptoms. I wouldn't recommend fasting diets or this 5-2 diets when you eat for 5 days and fast for 2, or even longer night fast is probably not good for the disease itself. So I'd say small meals, but often, and avoid the excess fat and sugar. That's good for the general health as well.
Okay. Last question?
Well, no, it's not a question, it's just a complementary information about the magnesium, because all supplements are not the same effect. If you take citrate, you have an effect on digestive motility, but if you have magnesium with glycinate, it's more tolerate. That means if for some of you we need to take magnesium supplement, take with glycinate. It's a nephrologic view for the magnesium supplement.
Okay, thank you. We can move to the next. We can move to the next speaker, Professor Bonderman from Vienne, talking about the cardiac aspect of the disease.
Yeah. Good afternoon, ladies and gentlemen, dear chairpersons. It's a pleasure to be here to give my presentation on the symptomatic management of ATTR amyloidosis and cardiac aspects. My conflict of interest. So when I first read the invitation to give this presentation, so it was quite difficult for me to imagine what to talk about, because clearly there is no guidelines or guidance what to do with from the symptomatic point of view with ATTR cardiomyopathy patients. So we have the guidelines or we have the data or evidence on the silencers, gene silencers, also on the stabilizers, but there is actually basically very few guidance on what to do with the patients. So you just can sit there and tell your patient, we do They make a specific treatment, but we don't care. We can't do anything with the symptoms. That's one way you can go. The other way you can choose is you just go beyond anything and beyond guidance and beyond guidelines. You just do everything for your patient you can think of and that makes sense for your patient. And the picture I have in mind when I'm treating patients with really freestyle with ATTR cardiomyopathy. It's an old movie, 25 years old, called Tiger and Dragon. Maybe you saw it. And I think the specific or the part that I like about the movie that you have a lot of, like fighters. They're like kung fu or whatever fighters. It's a martial art movie. And they just develop a very high virtuosity in fighting, and they're really good when you look at that. But there is a small subgroup of the fighters who just don't follow the rules of physics. They just leave the gravity. They just do whatever is freestyle, and the good thing about it, they always win. So I think that's the way to go with symptomatic management of ATTR cardiomyopathy. So symptoms may arise from, and I think you had that in the previous session with Marianna Fontana, who said that, yes, you have the specific problem, the trigger, it's the amyloid deposition, but then patients go into heart failure, and that's actually all patients present sometime eventually with heart failure symptoms. But symptoms could also arise for rhythm and conduction disorders. They could also arise, and Marianna showed it, from valvular pathologies, but also they can arise a little bit, but in some patients, very mildly, but also from the pulmonary circulation. And this is actually the way you can see and treat the patient in addition to specific treatment. And actually there is not much data out, but this is what we're doing, and I tried to find some literature on that, and that's just a reminder, and I'm sure that's about heart failure, and I'm sure you're familiar, because for the sake of time, I'm not going to the difference between the normal and the abnormal, but I think the main point I want to say that in the beginning, most of the patients have I don't know, you see it? Yes. So it's a stiff heart, so there is a difficulties in filling the left ventricle, but once the disease continues and goes on, it's also a reduction in ejection fraction, but it's certainly heart failure. So when we look at heart failure patients not caused by ATTR cardiomyopathy, most of them would be heart failure patients not by ATTR amyloidosis. We have 4 pillars of treatment, and these are class 1 indications in the current guidelines. And we have the group of ACE inhibitors and ARNI, we have the group of beta blockers, we have the group of mineralocorticoid antagonists and SGLT2 inhibitors, so class 1A indication. But what about patients with cardiac amyloidosis? We don't have the data for that, and this is just a short summary showing how we still can use the medication in our patients. So the cardiac amyloidosis patient goes into, so first starts with HFpEF, then continues to go into reduced ejection fraction. And I think one of the major or the main armamentarium we have to treat the patients diurese the patient. So if you diurese the patient, you get the water off the patient, he feels immediately better. But what about this? So you relieve the congestion, what about this? So ARNI and ACE inhibitors, frequent intolerance, may be used in caution in your patients. Beta blockers should be avoided. What about mineralocorticoid antagonists? Actually, we use them, and also the SGLT2 inhibitors, we use them as well, because they're pretty safe, and there is a little bit of evidence out there. And finally, heart transplantation. And we have also some of the patients, advanced heart failure patients with ATTR cardiomyopathy, who went to cardiac transplantation with a good result. So the ARNI, I didn't find much of the literature out there, but there was a recent study, it's a case series on 6 patients with ATTR cardiomyopathy and treated with sacubitril valsartan. I think the main message here is that you can't go titrate the patient up to the final doses, to the target doses. So all of the patient went well, but the dose is limited to the lower medium level. I think that's the main message. There is a little bit of evidence from spironolactone from the TOPCAT trial. TOPCAT was spironolactone in HFpEF, and post hoc there was an analysis on a subgroup of patients who fulfilled diagnostic criteria, but echo criteria, so it's not, but it could be, they have a high probability of ATTR cardiomyopathy, and there was evidence from the trial that spironolactone could improve outcome, and outcome means also symptoms. There is another study on SGLT2 inhibitors, and we use them in clinical practice on a regular basis because we know they're safe. And what was shown in this study is it's a retrospective analysis, but what was shown that you can reduce the maintenance dose of loop diuretics, you can reduce weight, so the water goes away, the kidney function remains stable, you can reduce uric acid, and antiprobenpine, troponin, the biomarkers are still also a little bit improved. So I think that's a good suggestion, just this is what we do on a regular basis, and I think there is even data out there to support this in clinical practice. Rhythm conduction in disorders, this is more or less freestyle, so I just found a recent study published this year, and this was basically based on the Delphi questionnaire, and there were 56 panelists, and they were asked, would you agree to proceeding with devices or other rhythm disorders? And actually there were 177 statements submitted to them, but there was only little agreement, and I just show you the agreement. So the panelists agreed that rhythm control is important using amiodarone. They also agreed that ablation of atrial fibrillation might be a choice in early stages of the disease. And they also agreed that there is indication on device implantation, but the question is, as you can see here, there's even more gaps of evidence and research needed than what they agreed upon. Valvular heart disease was also managed, and I'm sure you're familiar with the data. So aortic stenosis patients, 8% of them would also have concomitant cardiac amyloidosis. And if you go to the subgroup of low flow, low gradient aortic stenosis patient, it even rises to 25%. So there is like comorbid conditions. So what to do with the patients? Of course, the aortic stenosis, you improve survival and to improve symptoms by treating the aortic valve. And the same is true for cardiac amyloidosis patients with aortic stenosis. The only thing is that you would, and this was a retrospective analysis from Spain, comparing AS patients with and without amyloidosis undergoing TAVI procedures, so transcatheter aortic valve implantation. Those with cardiac amyloidosis had a little bit worse prognosis, worse outcome, and they had also they were more symptomatic. They had acute heart failure, stroke, and pacemaker implantation in long term after TAVI procedure, but still they benefited, but less than aortic stenosis patients without cardiac amyloidosis. And the other interesting development now from a scientific point of view, so you know that we have mitral regurg. This was a study and tricuspid regurg in these patients, and this was a study from 3 Italian centers showing that once the disease progresses, there is more and more mitral and tricuspid regurg, and this has also to do with, this also impacts outcome and survival of these patients. So what to do with these patients? And actually this is something that we have addressed together with the Medical University of Vienna in a millennial trial, and this is actually currently recruiting patients in multiple sites in Austria. As you can see here, this is the inclusion criteria is ATTR cardiomyopathy, significant mitral regurg, and then symptoms. Patients have to be symptomatic, and they just go to a transcatheter procedure, so edge-to-edge repair of the mitral valve with optimal medical therapy compared against optimal medical therapy. This is ongoing for 48 months, and then we'll hopefully see the results, and we'll see whether we can help the patients to improve with respect to their symptoms. And the final statement or a final possibility to improve symptoms is also to act on the pulmonary circulation. So, you know, Riociguat is a soluble guanylate cyclase stimulator that has been licensed for the treatment of precapillary pulmonary hypertension. And we have shown in the dynamic study, it was 3 years ago, that it's also at least safe and effective in patients with post-capillary PH, with heart failure, with preserved ejection fraction. But we don't, this was published 3 years ago, I think. It was a placebo-controlled trial. But we don't know anything about the pulmonary circulation of, and whether riociguat would work in cardiac amyloidosis patients. And this is a named patient program that we did a couple of years ago in the Medical University of Vienna. And we just did right heart cath for baseline. And those patients who exhibited post-capillary pulmonary hypertension, but usually it's really mild, but still it's there, we would treat with riociguat. And what we saw is that we could improve the patients hemodynamically, meaning that they improved cardiac output, and they are also improved with respect to exercise quality of life. So they have a clinical improvement as well. So this is what we do with our patients. It's really freestyle, I think, but I would like to summarize here. So management, as I said, of cardiac symptoms goes beyond guidelines. Most important for the patient, and I'm sure it's your experience, is euvolemia. Just get the water out and the patient feels better. Rhythm control is important. If you can't control the rhythm, just control the rate. If patient with a stiff heart go into tachycardia, there is no time to fill the ventricle, and this makes the patients highly symptomatic. Device therapy is there. It's also recommended to treat concomitant valvular heart disease, at least, of course, aortic stenosis. We will have the data about mitral regurg. And post-capillary pulmonary hypertension might be an issue. Even if mild, we can safely treat the patient that there is evidence that they could benefit symptomatically. And I would like to thank you for your attention.
Okay. So, thank you. Questions? No question. Okay. Okay, sorry, we are a little late, so we are now ready for the photo, picture, and then lunch. Thank you for everyone, for every speaker.